Okay, picture this. You've got an older patient sitting in your clinic. They are just totally exhausted, dealing with severe fatigue. Maybe they've had a few recurring infections lately, and you notice they're bruising and bleeding super easily. Naturally, you run some blood tests, and their counts are terribly low. Now, you might be thinking, well, their bone marrow must be empty, right? It's just failing to produce cells. So you go ahead and do a bone marrow biopsy. But when you look under the microscope, it is not empty at all. Actually, it's hypercellular. It is literally packed with cells. This right here is the fascinating medical mystery we are unraveling today. Welcome to this explainer on myelodysplastic syndromes. So what's going on here? This is the core paradox of the disease. You have a marrow completely full of cells, yet the peripheral blood counts, the ones actually in circulation, are dangerously low. Why does this happen? Well, the answer is that myelodysplastic syndromes, or MDS for short, are pre-leukemic disorders, where the actual production of the blood cells is fundamentally flawed. The body's making them, sure, but they are completely defective. All right, let's look at the roadmap for this explainer. We're going to cover the MDS paradox, pathophysiology and AML risk, clinical symptoms, diagnosis, treatments, and wrap it all up with some high-yield exam pearls. Let's dive in. Section 1. The MDS paradox explained, and understanding the basics. To truly get what goes wrong in MDS, we first need to establish the baseline of normal blood cell development, a process called hematopoiesis. Think of it like a highly regulated factory. It all starts with a healthy hematopoietic stem cell. Through a very precise number of divisions in the bone marrow, this single starter cell eventually matures into 3 essential types of blood cells. We get our red blood cells to carry oxygen, our white blood cells to fight off infections, and our platelets that help form clots so we don't bleed out. And here's the key. Only when these cells are fully mature and ready to do their jobs do they actually leave the bone marrow and enter the bloodstream. Moving to Section 2, Pathophysiology and AML risk, or basically when hematopoiesis goes wrong. So in MDS, those initial hematopoietic stem cells in our factory become damaged. Instead of producing fully functional mature cells, they pump out these faulty, immature blood cells that we call blasts. Because they're defective, they basically get stuck. They fail to mature, persisting as useless, immature cells. And this brings us right back to our core paradox. We call this ineffective hematopoiesis. These blasts usually just die right there in the bone marrow, or maybe shortly after they manage to sneak into the blood. You absolutely cannot count on them to do the job of healthy, mature blood cells. And it gets worse. As the condition progresses, these useless blasts multiply and gradually take over the bone marrow, physically crowding out and displacing whatever normal, healthy cells are left. Now, you're probably wondering, what causes this stem cell damage in the first place? While it can affect anyone, it's overwhelmingly seen in people over the age of 60. And honestly, in most cases, the exact cause is completely unknown. We classify this as primary MDS, and it's by far the most common form. On the flip side, we have secondary MDS. This is much rarer, but it happens when the genetic damage to the stem cells is actually caused by something specific, like prior chemotherapy, radiation therapy, or exposure to severe toxins like benzene. Okay, this is a massive point right here. Look at this specific number, 20%. MDS isn't just one static thing. It's a spectrum of diseases, and it generally gets worse over time as the bone marrow fails. But the absolute most terrifying complication is its potential to progress into an aggressive cancer. If the proportion of those useless, immature blasts in the bone marrow crosses that 20% threshold, the disease has officially deteriorated into acute myeloid leukemia, or AML. And tragically, this drastic transformation happens in 40 to 50% of all MDS cases. Section 3. Recognizing the clinical symptoms and the rule of threes. Since those mature cells aren't making it into the bloodstream, we see a clinical triad of symptoms across the 3 main blood cell lines. First up, a drop in red blood cells causes anemia. This is actually the most common feature of MDS, and it leads to dizziness, irritability, headaches, and noticeably pale skin. Second, low white blood cell levels leave the patient highly vulnerable, massively increasing the risk of severe bacterial and fungal infections. And third, low levels of platelets mean the blood simply can't clot properly. This results in excessive bruising from even tiny bumps and incredibly easy bleeding. Section 4. Diagnosing myelodysplastic syndromes by looking at the blood and marrow. So how do we actually confirm this? It requires 4 specialized tests. We usually start with a complete blood count, or CBC, which will typically show those low levels in 1, 2, or all 3 of the blood cell types. Next, a peripheral blood smear lets us actually lay eyes on the cells. Instead of normal shapes, we might see classic dysplastic signs, things like macroovulocytes, hypogranular neutrophils, or those weird Pelger-Howitt-like cells. But the real clincher is the bone marrow aspiration and biopsy. This is the test that physically proves our core paradox. It shows an increased cell count, but packed with clear, dysplastic, completely abnormal changes. Finally, we run a chromosome analysis to hunt down specific genetic abnormalities, like a deletion of 5q, monosomy 7, or trisomy 8. Section 5. Treatment and Management Strategies Targeting the Risk Level. When it comes to treatment, it is entirely dependent on the patient's clinical risk status. Basically, we need to know their risk of developing leukemia versus just remaining stable. We figure this out using the IPSSR, or International Prognostic Scoring System Revised, which looks at their blood counts, the proportion of blasts, and those chromosome abnormalities. For low-risk patients, the goal is pretty straightforward: improve their blood counts. We can use growth factors like erythropoietin for anemia or GCSF for neutropenia. If they happen to have that specific chromosomal abnormality known as 5q-, we can actually treat them very effectively with a drug called lenalidomide. Sometimes we even use immunosuppressive therapy with anti-thymocyte-globulin. Now, for high-risk patients, the whole target shifts to preventing AML progression. Here we bring in the heavy hitters, hypomethylating agents like azacitidine or decitabine. But listen to this. Across the board, no matter the risk level, if we want a true, definitive cure, the absolute only option is a bone marrow stem cell transplant from a healthy donor. Now, beyond trying to modify the disease itself, supportive care is absolutely vital for managing a patient's day-to-day life. We're talking red blood cell transfusions to correct that exhausting anemia, platelet transfusions to prevent a serious bleed, and antibiotics to keep infections at bay. But there is a major catch here. Getting frequent, multiple transfusions can actually cause a highly dangerous buildup of iron in the patient's body. If that starts happening, we have to step in with an iron chelating agent like deferricerox to bind to that excess iron and safely flush it right out of their system. Section 6. High-Yield Exam Pearls. Time for a rapid review.
All right, if you take nothing else away from this explainer, remember this defining diagnostic paradox. MDS is characterized by peripheral cytopenias, those low blood counts, happening right alongside a hypercellular packed bone marrow. The factory is working, but the production is completely ineffective. And you absolutely must contrast this with the disease's greatest, most terrifying risk, that life-threatening transformation into acute myeloid leukemia. And remember, that alarm bell is officially triggered the exact moment those useless blast cells exceed 20% in the marrow.
On the pharmacology side of things, lock in this highly specific treatment pairing. The drug lenalidomide is your go-to for patients presenting with that 5q- chromosomal mutation. But never, ever forget that no matter what medications we use to manage the symptoms or slow things down, the single, absolute, only curative option for MDS remains a bone marrow stem cell transplant. I want to leave you with one final, incredibly powerful thought that really changes how we look at hematology. Not all bone marrow failure is low production. Sometimes it is ineffective production. It's a subtle distinction, sure, but a profound one that dictates exactly how we diagnose these patients and ultimately save lives. So the next time you see inexplicably low blood counts, just remember to ask yourself, is the factory empty or is it just producing broken parts? Thank you so much for joining us for this explainer. See you in the next one.